This is a quick review of basic ventilator setup or initial ventilator settings. The most common reason for instituting mechanical ventilation is to treat respiratory distress in patients who are unable to achieve effective gas exchange. This goal can be accomplished by setting an appropriate tidal volume and respiratory rate or frequency to achieve a desired minute ventilation. We will examine how minute ventilation and other variables are set during the initiation of volume ventilation, then focus on the settings required to initiate positive pressure ventilation. Initiating volume control ventilation for a patient requires an understanding of the interaction of several key variables, including minute ventilation settings such as your tidal volume and frequency, inspiratory gas flow, flow waveform, your IE ratio, pressure limit, your inflation hold or inspiratory pause, and inspiratory pressure and positive and expiratory pressure or PEEP. The primary goal of volume-controlled continuous mandatory ventilation is to achieve a minute ventilation that matches the patient's metabolic needs. A typical healthy person at rest has a total oxygen consumption of 250 mLs per minute and a carbon dioxide production of about 200 mLs per minute. As the patient's metabolic rate increases, ventilation must change to meet the needs for increased oxygen uptake and CO2 removal. Metabolic rate is directly related to body mass and surface area in humans. Measurements of heat production, such as direct calorimetry, provide a reliable method to quantify metabolic rate. However, direct calorimetry requires a considerable amount of space and time commitment and is typically reserved for research purposes. Indirect calorimetry, which uses measurements of inspired and expired oxygen and carbon dioxide to estimate energy expenditure, can be accomplished with significantly less time and effort. Advances in computer technology have made it relatively easy to perform indirect calorimetry in the clinical setting. A more commonly used method to estimate metabolic rate and caloric intake involves using equations that were derived from laboratory studies performed in the early part of the 20th century, like scientists Harris and Benedict. With these equations, metabolic rate is estimated on the basis of an individual's gender and body surface area. BSA, the body surface area, can be calculated using the Dubois BSA formula. Refer to your course instructor and your textbook for examples on how to calculate your BSA and your tidal volume, respiratory rate, and minute ventilation. In many cases, physicians order settings for mechanical ventilation that includes volume and rate and do not typically specify minute ventilation. You, as a respiratory therapist, must keep in mind that the ordered rate and volume must reflect the minute ventilation needs of the patient. The normal spontaneous tidal volume for a healthy adult is about 5 to 7 mLs per kilo, with a spontaneous respiratory rate of 12 to 18 breaths per minute. Minute ventilation is about 100 mLs per kilo of ideal body weight. When determining tidal volume for ventilated patients, a range of 6 to 8 mLs per kilo of ideal body weight is typically used for adults, and 4 to 8 mLs per kilo of ideal body weight for infants and children. Lower tidal volume rates, such as 4 mLs per kilo of ideal body weight, have been successfully used to ventilate the lungs of adult patients with acute respiratory distress syndrome, or ARDS. These lower tidal volume rates are described as protective strategies that minimizes the damaging effects associated with overdistension of the alveoli. It is also important to understand that an adult's lungs do not get larger as he or she gains weight. A good example is a 5'6" adult male weighing 100 kilos would require the same tidal volume as a 5'6" adult male weighing 65 kilos. Remember, however, that a heavier patient would have higher metabolic rate and thus a higher minute ventilation. When setting tidal volume and rate, the goal is not to focus so much on the exact tidal volume and rate, but to focus on using settings that do not harm the patient. Maintaining plateau pressure lower than 30 centimeters of water pressure is very important. In some cases, it may even be necessary to let the PaCO2 rise and pH fall outside the patient's normal values to avoid lung injury. Recommended tidal volumes for ventilated patients vary depending on the lung pathology. For patients with normal lungs, such as patients with a drug overdose or patients with post-operative effects of anesthesia, an initial tidal volume of 6 to 8 mL per kilo and a rate of 10 to 20 breaths per minute is generally accepted. In patients with chronic obstructive pulmonary disease and asthma, in which airway obstruction and resistance are high, an initial tidal volume of 6 to 8 mL per kilo with a rate of 8 to 12 breaths per minute is acceptable. In restrictive diseases, lower tidal volumes and higher rates are used. However, high rates may not provide sufficient time for exhalation, which is very short exhalation time, and air can be trapped in the lungs at the end of exhalation, resulting in intrinsic PEEP or auto PEEP, or air trapping. The tidal volume should be adjusted to maintain plateau pressure of less than 30 centimeters of water pressure and rates adjusted to minimize auto PEEP. A tidal volume of more than 9 to 10 mL per kilo is not recommended because of the risk of high pressures and accompanying overdistension and trauma to the lung, in addition to other complications. Low volume settings, such as 4 to 8 mL per kilo, are beneficial in restrictive diseases and may help prevent high pressures and alveolar overdistension. It is worth mentioning that using volumes as low as 4 mL per kilo may contribute to atelectasis. Using tidal volumes this low may require a recruitment maneuver or sigh breaths to avoid atelectasis. In addition, use of lower tidal volumes may be especially important in patients receiving PEEP therapy to avoid high pressures and overdistension. Please review your equations for the tidal volume, flow rate, inspiratory time, expiratory time, total cycle time, and respiratory rate. Refer to your course instructor and your textbook. During volume controlled ventilation, the clinician may have the option to select a variety of ventilator flows and flow patterns. The flow setting on a mechanical ventilator determines how fast the inspired gas will be delivered to the patient. During controlled mechanical ventilation, or CMV, high flows shorten I time and may result in higher peak pressures and poor gas distribution. Conversely, slower flows may reduce peak pressure, improve gas distribution, and increase mean airway pressure at the expense of increasing inspiratory time. Unfortunately, shorter E time can lead to air trapping, and using a longer I time may also cause cardiovascular side effects. In reality, actual normal inspiratory times have never been measured, and much of clinical practice involved in setting appropriate I time requires clinician observation of the patient's response to the set values, and these may require some adjustments. Selecting the most appropriate flow pattern and ventilator rate depends on the patient's lung condition. For example, post-operative patients recover from anesthesia may have very modest flow demands, whereas a young adult with pneumonia and a strong hypoxemic drive would have a very strong flow demand. The most common flow patterns used clinically are the constant flow and descending or decelerating flow waveforms. Clinicians often select the constant flow pattern simply because it is the most familiar to them, or it is the only one available on the ventilator in use. Constant flow pattern are also called rectangular or square waveform. For initiating ventilation, a rectangular flow pattern is acceptable. Generally, a constant flow pattern provides the shortest I time of all the available flow patterns with an equivalent peak flow rate setting. On the descending ramp, the amount of gas flow delivered at the beginning of the breath is probably the major determinant of patient effort and work of breathing. A descending or decelerating flow waveform has a distinct advantage compared with other waveform patterns. With a descending pattern, flow is greatest at the beginning of inspiration when patient flow demand is the highest. The descending waveform occurs naturally in pressure ventilation. Most clinical studies designed to investigate the effects of various ventilator waveforms have compared the constant waveform with the descending ramp. As one changes from a constant to a descending ramp, peak pressure is lower and mean airway pressure is higher. Studies comparing the descending flow pattern with the constant flow pattern suggest that the descending flow pattern improves the distribution of gas in the lungs, reduces dead space, and increases oxygenation by increasing mean and plateau airway pressure. It is important to remember that in situations where plateau pressure is critical, changing to a descending ramp to reduce peak pressures may increase the mean airway pressure. The clinician must decide whether mean airway pressure is more important for the patient. There are concerns of high peak inspiratory pressure when selecting a particular waveform. When airway resistance and flows are high, peak pressures will be high if an ascending flow pattern is used. Much of this pressure is dissipated in overcoming the airway resistance and may not reach the alveolar level. Thus, high peak pressure do not always increase the risk of damage to the lungs. An example of a patient population in which this can occur involves patients with acute asthma experiencing severe bronchospasm, mucosal edema, and increased secretion production. It is important to recognize, however, there is a risk that some of the high pressures may reach normal lung areas, which could be damaging in this group of patients. The inspiratory pause or inflation hold, also called end inspiratory pause, is a maneuver that can be performed by preventing the expiratory valve from opening for a short time at the end of inspiration when the inspiratory valve is also closed. Most ICU ventilators have an inspiratory pause button or control. The inspiratory pause maneuver is used to obtain measurements of plateau pressure, which allows estimation of the alveolar pressure for the calculation of static compliance. Inspiratory pauses can also be selected for use with each mandatory breath to improve the distribution of air throughout the lungs, regardless of the type of flow pattern used. It is believed that an inspiratory pause provides a longer inspiratory time, which in turn provides optimum VQ matching and reduces dead space to tidal volume ratios. This maneuver must be used with care or not at all in patients with COPD and flow limitation. Inspiratory pause with each breath is not commonly used in clinical practice because it may significantly increase mean airway pressure and reduce pulmonary blood flow. Pressure-targeted ventilation provides a set pressure to the patient during breath delivery, whereas tidal volume can vary from breath to breath. There are several methods to provide a pressure breath that should be considered. This begins with baseline pressure and then includes pressure support ventilation, pressure controlled ventilation, and other modes such as your bi-level positive airway pressure and other dual control modes. Each of these modes has specific controls that are set by the operator. Less frequently used pressure targeted modes, such as the pressure controlled inverse ratio ventilation and airway pressure release ventilation, will be reviewed at a separate topic and a separate lecture. Volume targeted ventilation has the advantage of guaranteeing volume delivery. However, it has the disadvantage of increasing PIP as lung compliance decreases and airway resistance increases. Overinflation is also a risk. Pressure targeted breaths have the advantages of providing flow on demand and potentially limiting pressures to avoid overinflation. With pressure targeted breath delivery, rapid initial flows may cause frictional forces or shearing between adjacent alveoli with differing lung inflation characteristics. In addition, tidal volume varies as lung characteristics change. There currently are no definitive studies that have demonstrated a clear advantage of one method over the other. Functional residual capacity, or FRC, frequently decreases when a patient is intubated or placed in a supine position. In most situations, it is appropriate to use the minimum levels of PEEP, such as 3 to 5 centimeters of water pressure, to help preserve a patient's normal FRC. Because only a modest amount of pressure is applied with this minimum level of PEEP, it is not considered a problem in terms of causing complications. In fact, not using a low level of PEEP may result in atelectasis. Use of low levels of PEEP may also be beneficial in patients with chronic obstructive pulmonary disease who would normally press to breathe but cannot do so with an artificial airway in place. In any pressure targeted breath, the difference in pressure or the change in pressure between baseline and PIP determines what is set to establish tidal volume delivery. Volume delivery will also be affected by the patient's lung characteristics and any patient effort that is present. There are two ways to set the pressure in pressure targeted breaths to provide the desired tidal volume. One way is to deliver a volume targeted breath to the patient at the desired tidal volume and measure plateau and baseline pressures. Using the same baseline pressure, the breath can be switched to pressure targeted breath using a set pressure equal to the plateau pressure. The resulting tidal volume will be approximately equal to the tidal volume during the volume breath as long as inspiratory time is set appropriately. The pressure can then be adjusted as necessary to obtain the desired volume delivery. Tidal volume should always be continually monitored. A second method to initiate pressure ventilation is to start at a lower pressure, such as 10 to 15 centimeters of water pressure, and check the tidal volume before readjusting the pressure to attain the desired volume. Usually, pressure support ventilation is started after the patient has been on full ventilatory support and is being changed to partial support to begin the process of discontinuing ventilation. Pressure support ventilation, or PSV, is used to support spontaneous breath in a patient with an artificial airway when IMV or spontaneous or CPAP modes are used. The pressure is set at a level sufficient to prevent a fatiguing workload on the respiratory muscles. Some clinicians recommend calculating the level of pressure support based on an estimation of total ventilatory system resistance determined while the patient is receiving volume control, CMV. The resistance of the patient and the ventilator circuit during this VC-CMV with constant flow can be estimated with the following equation, which is the area resistance equals to PIP minus plateau divided by flow. It is probably easier and just as effective to set the initial PSV equal to the trans-airway pressure, or the estimation of PIP minus plateau, after establishing these values with volume control CMV. The level of PSV can be adjusted once it has been initiated to an adequate level. Sometimes simply asking the patient if he or she feels it easy to breathe and if he or she is getting enough air helps in adjusting initial PSV. Appropriate adjustment of PSV level can be done at the bedside. The goals of adjusting PSV is threefold. First is to help increase or augment tidal volume to about 4 to 8 mL per kilo. to decrease the respiratory rate to less than 30 breaths per minute, and to decrease the work of breathing associated with breathing through an artificial airway. For patients with lung disease, levels of 8 to 14 centimeters of water pressure are typically used to compensate for additional work associated with breathing through a tube and the ventilator system. For patients without lung disease, about 5 centimeters of water pressure should be adequate to compensate for the additional work of breathing. Rate, inspiratory time, and IE ratio are set in pressure control CMV as they are with volume control. The pressure gradient, or PIP minus PEEP, including auto PEEP, is adjusted to establish volume delivery based on patient's lung characteristics and effort. Initial pressure is set at the plateau pressure value determined during VC-CMV. It must be adjusted as necessary to achieve tidal volume. If plateau is not available, the peak pressure from VC-CMV minus 5 centimeters of water pressure can be used as a starting point. If volume readings are not available, an initial pressure of 10 to 15 centimeters of water pressure with simultaneous volume measurement and adjustment is appropriate. The pressure limit must be set because in some ventilators, pressure can be higher than the set pressure control level if the patient actively coughs. Low tidal volumes and high frequency alarms are also necessary. An important advantage of PC-CMV is that the alveolar pressure usually will not exceed the applied pressure. Setting a PIP of less than 30 centimeters of water pressure can therefore help avoid alveolar overinflation. Because it is not possible to measure alveolar pressure in all situations, PIP is maintained less than the set pressure. The patient's alveolar pressure can be estimated by observing the flow curve. If the flow drops to 0 before inspiration ends, then the applied pressure is reaching the alveolar level by the end of inspiration. If inspiration ends before the flow reaches 0, then alveolar pressure is less than applied pressure, but it's not measurable. In this case, inspiratory time may need to be adjusted depending on patient need and tidal volume delivery. Normally, pressure control CMV provides a descending ramp waveform. As with pressure support ventilation, or PSV, current generation ventilators are able to adjust the inspiratory rise time, which is the amount of inspiratory time required for the ventilator to reach set pressure at the beginning of inspiration. The practitioner can adjust the rise to meet patient needs as with PSV. It is advisable to use graphic monitoring to help make adjustments in pressure, eye time, and flow taper. If eye time is too long and the patient starts to actively exhale, a slight rise will occur at the end of the breath on the pressure curve. Compared with similar settings on volume control CMV, pressure control CMV has been shown to improve oxygenation and gas exchange, increase mean airway pressure, and facilitate lung healing. Pressure CMV also reduces the PIP, the amount of applied PEEP, minute volume, respiratory work, the need for sedation, and the duration of mechanical ventilation. Pressure-targeted ventilation is safe and well tolerated as an initial mode of ventilation in patients with acute hypoxemic respiratory failure and may result in greater patient comfort. Bi-level positive airway pressure can be used for intubated patients or non-intubated patients, although it is most used often as non-invasive positive pressure ventilation. Initial settings included inspiratory positive airway pressure, or IPAP, of 5 to 10 centimeters of water pressure. The level of IPAP is increased in increments of 3 to 5 until a rate of 25 breaths per minute or lower is achieved, and the tidal volume is 4 to 8 mLs per kilo or more, depending on the patient's pathology. Expiratory positive airway pressure, or EPAP, or PEEP, is initiated at 2 to 5 centimeters of water pressure and increased in increments of 3 to 5 centimeters of water pressure. The initial FiO2 is set to ensure adequate oxygenation. It is important to recognize that initiating NIV may require a considerable amount of time to achieve patient compliance. The goal of selecting a specific FiO2 for a patient is to achieve a clinically acceptable arterial oxygen tension, usually 60 to 100 millimeters of mercury. To accomplish this goal, a baseline ABG should be performed. If the patient's partial pressure of arterial oxygen, or PaO2, is within the desired range before beginning ventilatory support, the FiO2 that the patient is receiving at the time of the baseline ABG can be used when mechanical ventilation is initiated. If PaO2 is not within the desired range, the following equation can be used to estimate your FiO2, which is the desired FiO2 equals PaO2 desired times your known FiO2 divided by your known PaO2. This relationship is based on the assumption that the patient's cardiopulmonary function will not radically change from the time of the baseline ABG to the time when mechanical ventilation is initiated. Some changes will obviously occur because the application of positive pressure ventilation can affect a patient's cardiopulmonary status. If a baseline ABG is not available, it is advisable to select a high initial FiO2 setting for patients with presumed severe hypoxemia. This can provide a way of restoring normal oxygenation and replacing tissue oxygen storage when oxygen debt and lactic acid accumulation have occurred. Many practitioners start with an FiO2 100 or 1.0 and then reduce it as quickly as possible. Extended use of 100% O2 is not recommended because it can quickly result in absorption atelectasis and in long term can lead to oxygen toxicity. It is important to know, however, that 100% oxygen should not be withheld if the patient is seriously ill and requires a high FiO2. Any procedure that places the patient at risk of developing hypoxemia should be performed with the patient breathing 100% oxygen. For example, administering 100% O2 before and after suctioning and also during bronchoscopy is a common practice. Ventilator sensitivity is normally set so that patients can easily flow or pressure trigger a breath. Flow triggering is set in a range of 1 to 10 liters per minute below the base flow, depending on the selected ventilator. Pressure sensitivity is commonly set between -1 and -2 centimeters of water pressure. Many clinicians prefer using flow triggering because it provides a slightly faster response time compared with pressure triggering for two main reasons. First, the exhalation valve does not have to close during flow triggering. With pressure triggering, the exhalation valve must close and the patient's inspiratory effort has to be sufficient to reduce the circuit pressure to the trigger setting. And secondly, during the pressure triggering, the circuit pressure has to drop before the inspiratory valve opens and flow goes to the patient. In contrast with flow triggering, the pressure does not need to drop because the inspiratory valve remains open and the patient receives almost immediate support. If auto PEEP, intrinsic PEEP, or dynamic hyperinflation is present, or air trapping, patients often have trouble triggering a breath. Indeed, in cases when auto PEEP is very high, patients may not be able to trigger a breath at all. It can therefore be particularly difficult when a high level of auto PEEP is present to adjust the ventilator sensitivity so that it senses a patient's effort. Furthermore, the cause of the problem goes often unresolved unless auto PEEP is detected and measured. The patient must generate a -1 to -2 centimeters of water pressure to trigger inspiratory flow. As Spontaneously breathing individual inspired air is typically conditioned down to the fourth or fifth generation, or subsegmental bronchi, such as in this case, the isothermic saturation boundary, or ISB. Under normal circumstances, conditioning of inspired air occurs as air passes through the nose and upper airway. Because these are bypassed during invasive ventilation, a humidity source must be added to the ventilator circuit. Humidity can provide a variety of heated humidification systems. Devices in this category include the passover, vapor phase, wick, and active heat and moisture exchanger. Refilling heated humidifiers is best accomplished by using closed feed system. With a closed feed system, the water level in the reservoir is either maintained manually by adding water from a bag through a fill port or by a float feed system that maintains a relatively constant water level. Heated humidifiers typically include a servo-controlled heater with a temperature probe that is placed close to the patient's airway. These devices typically equipped with a temperature display and a temperature alarm. The high temperature alarm is set at 37 degrees to 38 degrees Celsius so that the inspired gas does not exceed 37 degrees Celsius. A minimum alarm setting of 30 degrees Celsius is appropriate. Whenever the temperature in the patient circuit is less than the temperature of the gas in the leaving the humidifier, condensate accumulates in the circuit. Notice that condensate accumulation or rainout will increase as the temperature becomes cooler. Heat moisture exchangers, or HMEs, also called artificial noses, can be used for humidification in patients receiving mechanical ventilation. However, there are some circumstances when HMEs should not be used. HMEs can provide 10 to 14 grams per liter of water at tidal volumes of 500 to 1,000 mLs. More efficient hygroscopic heat and moisture exchangers can provide 22 to 34 milligrams per liter at similar volumes. Because the net heat and water loss occurs when HMEs are used for extended periods, the patient should be assessed for signs of drying secretions. HMEs should be taken out of line during delivery of an aerosolized medication. It should be kept in mind, however, that circuit disconnection increases the risk of circuit contamination. An alternative approach is the use of a meter-dose inhaler, or MDI, with an adapter placed between the HME and the endotracheal tube. If a spacer is used with the MDI on the inspiratory line, the HME must still be removed. Another solution is to use a circuit adapter that does not require the HME to be removed during aerosol treatments. Audible and visible alarm systems are designed to alert the clinician of potential problems related to the patient-ventilator interaction. This section reviews the most commonly used ventilator alarms and how they are set by most clinicians. Levels of alarm and example events during mechanical ventilation are: level 1, immediately life-threatening, such as electrical power failure, no gas delivery to the patient, exhalation valve failure, excessive gas delivery to patient, and timing failure. Level 2 are potentially life-threatening, such as circuit leak, circuit partially obstructed, heater or humidifier malfunction, inspiratory to expiratory ratio inappropriate, inappropriate oxygen levels, auto-cycling, inappropriate PEEP or CPAP level. And level 3, not life-threatening, but a potential source of patient harm, are changes in the lung characteristics, high respiratory rates, auto-PEEP, and changes to ventilatory drives. Before initiating mechanical ventilation, the respiratory therapist should perform a final check of the equipment to be used. This check should include the following steps. Other final considerations in the setup are prepare the patient, establishing an interface, provide manual ventilation, ensure cardiovascular stabilization, determine ventilator needs, and treat the cause of respiratory failure. In preparing the patient, mental preparation of a patient will require mechanical ventilation is an obvious part of preoperative planning for patients that will likely need short-term post-operative ventilatory support. It is an important part of patient preparation because it can significantly reduce the patient's anxiety and discomfort. Before initiating mechanical ventilation, conscious patients must be prepared for what to expect once they are connected to the ventilator. The clinician should give a brief explanation about how the ventilator works and why it is being used. The patient must also be informed that the use of an artificial airway will inhibit verbal communication. Unconscious patients should be informed about their situation as soon as they regain consciousness. This is crucial because these patients will be unable to speak and may be completely unaware of what has occurred. Often, the explanation will need to be repeated because sedatives and similar agents can alter a patient's mental status. For non-invasive ventilation, a face or nasal mask is snugly fitted. During invasive ventilation, the three most commonly used artificial airways are orotracheal, nasotracheal, and tracheostomy tubes. Orotracheal tubes are used for emergencies and are generally kept in place for several days. Nasotracheal tubes provide better patient comfort but may require more insertion time. Nasotracheal tubes usually have smaller diameters than orotracheal tubes and are associated with increased incidence of sinus infection. Tracheostomy tubes must be inserted surgically, but these tubes can be used for extended periods. They will also allow for easier pulmonary hygiene and are apparently most comfortable for the patient, even allowing the patient to talk in some cases. Before initiating mechanical ventilation, the patient's ventilatory requirements can be supported by using a manual resuscitation bag. These devices are easy to operate and allow the clinician to monitor closely the patient's breathing efforts and changes in airway resistance or lung compliance. The combined stress of acute or impending respiratory failure and endotracheal intubation can reveal undiagnosed cardiovascular complications, which may already be present. For example, patients with existing or borderline myocardial ischemia may develop cardiac dysrhythmias. The effects of any pharmacologic agents used during intubation, such as topical anesthetics, sedatives, narcotics, and muscle paralyzing agents, can lead to hypotension and relative hypovolemia, resulting in reduced venous return and cardiac output. Appropriate cardiovascular support is therefore essential to a successful outcome. After the patient's cardiovascular status is stabilized and primary ventilatory needs are being met, the clinician can then select the appropriate mechanical ventilator mode in appropriate ventilator settings. Once a life-threatening situation no longer exists, attention can be turned to treating the initial problems that cause the patient to require ventilation. Mechanical ventilation is not curative. The underlying problem must be resolved regardless of whether it is the result of central nervous system or neuromuscular problems or increased work of breathing caused by trauma, ARDS, or other obstructive pulmonary disease with complications. It makes little sense to be overly aggressive with palliative methods if the underlying pathology is irreversible. Guidelines for patients with obstructive diseases. Patients with COPD or chronic obstructive pulmonary diseases such as asthma, emphysema, and chronic bronchitis have increased airway resistance and may also have increased or decreased lung compliance, which when combined cause significant expiratory obstruction, lengthening the time constant, and lead to air trapping. When patients with obstructive pulmonary disease require mechanical ventilation, it is often because their chronic disease has been coupled with another problem, such as a respiratory infection, leading to an acute and chronic respiratory failure. Mechanical ventilation in obstructive pulmonary disease patients is associated with increased morbidity because of air trapping, nosocomial infections, barotrauma, and volutrauma, cardiac problems, aspiration, and difficulty weaning. The goals of mechanical ventilation are to maximize patient ventilator synchrony, reduce worker breathing and patient anxiety, and avoid the complications associated with mechanical ventilation, such as VAP or ventilator-associated pneumonia and ventilator-induced lung injury. Pressure-controlled CMV may be ideal for this group of patients for several reasons. PCCMV provides flow and demand to meet the patient's needs. Inspiratory time can be set along with a backup rate, but patient triggering is still permitted. PCCMV has a distinct advantage over PSV for this patient population because inspiration during PSV can be too long or too short depending on the patient's active breathing patterns. This can result in increased worker breathing and poor patient ventilator synchrony. Auto-PEEP can be a lethal complication. Current ventilators that allow an adjustable expiratory flow cycle may allow for the use of PSV in your obstructive pulmonary disease patients. An important part of patient care is providing adequate hydration and pharmacologic therapy, such as bronchodilators and corticosteroids, to reverse airflow limitations. Secretions must be mobilized and removed, and if infections are present, appropriate antibiotic medication must be administered. The primary problem necessitating ventilation must be corrected to ensure that weaning will be successful, because many of these patients are malnourished, and evaluation of their nutritional needs must be part of any follow-up program. Patients presenting with an exacerbation of acute severe asthma that requires mechanical ventilation are among the most difficult to manage. Increased airway resistance from bronchospasm, increased secretions, and mucosal edema increase the incidence of air trapping. Trapped air can cause an even hyperexpansion of various lung units, which can rupture or compress other areas of the lungs, leading to pneumothorax, pneumomediastinum, subcutaneous emphysema, and other forms of barotrauma. During an asthma exacerbation, the patient struggles to breathe while trying to move air against increasing loads. The result is dramatic changes in intrapleural pressure during inspiration and expiration that not only affects gas distribution in the lungs, but also alter cardiac function, resulting in pulsus paradoxus. Progressive hypoxemia further enhances the patient's drive to breathe and compounds anxiety. Even aggressive treatment with bronchodilators and steroids may not be enough to reverse the course of an acute asthma exacerbation. The primary goal during mechanical ventilation of these patients is to focus on reversing the high airway resistance while avoiding or reducing air trapping. If the patient has anxiety and the drive to breathe produces patient ventilator asynchrony during mechanical ventilation, then sedation and possibly paralysis may be required. Some of the indications for mechanical ventilation in asthma patients include exhaustion, such as respiratory rate progressively decreases and level of consciousness is altered, with developing metabolic acidosis and decreasing pH in the presence of a normal or rising carbon dioxide pressure. If audible, bilateral wheezes become distant as air trapping increases. Severe hypoxemia while receiving oxygen. Chest radiograph with depression of the hemidiaphragms and increased radiolucency suggestive of air trapping. Altered mental status, confusion, or decreased level of consciousness. Life-threatening dysrhythmias. And PaCO2 rises while pH declines. Cardiac or respiratory arrest. Other things to consider or some guidelines for patients with asthma that's being placed on mechanical ventilation can be found in the following screens. In acute respiratory distress syndrome, or ARDS, this is recognized as one of the most complex pulmonary disorders to manage. Mortality rates have been reported to range from 30 to 70%. There are characteristics, pathophysiological findings associated with ARDS include hypoxemia, increased pulmonary vascular permeability, bilateral radiographic opacities, venous admixture, increased lung weight, and decreased lung compliance. ARDS has been described as having two phases. An early phase, which is the first 7 to 10 days, which is characterized by increased vascular permeability, lung water, and lung protein, and a later phase, which is after 10 days, which is accompanied by extensive lung fibrosis. Management of ARDS inevitably includes mechanical ventilatory support. For patients with ARDS, a tidal volume of 6 to 8 mL per kilo with a respiratory rate of 15 to 25 breaths per minute is indicated. Use of lower than normal tidal volumes, such as 4 to 6 mL per kilo, may be necessary to maintain the plateau pressure to less than 30 centimeters of water pressure. This protective lung strategy has been shown to reduce the risk of ventilator-induced lung injury and improve outcomes for ARDS patients. As discussed in earlier chapters, it is important to remember that the use of high respiratory rates and low tidal volume may not provide sufficient time for exhalation and ultimately lead to air being trapped in the lungs during exhalation, such as auto-PEEP. The following are guidelines that are suggested for ventilating patients with ARDS. There is no evidence to date that pressure control CMV is superior to volume control CMV or vice versa. The selection of one mode over the other may depend on clinician comfort levels. If VC-CMV is selected, the clinician should use the descending flow waveform to help ensure early delivery of tidal volume and provide a higher mean area pressure than a constant flow pattern, which may benefit oxygenation and minimizes the difference between PIP and plateau. During the acute phase of the disease, patients typically require high levels of ventilatory support, although full support is usually not necessary. These levels can be attained with either CMV or IMV plus pressure support ventilation. Adequate ventilation can generally be provided with a tidal volume in the range of 4 to 6 mL per kilo, while plateau pressure is maintained at below 30 centimeters of water pressure with rates of 15 to 25 breaths per minute. The use of flow greater than 60 liters per minute for volume controlled ventilation. During pressure control, use of an I time that is long enough to enhance oxygenation, but short enough to allow adequate expiratory time to avoid auto-PEEP. Because time constants are short for many lung units, especially with decreased compliance, this is usually not difficult even for the IE ratios of 1 to 1.5 or higher. Extrinsic PEEP is required for the management of ARDS to prevent the opening and closing of alveoli during each breath. This opening and closing can cause lung injury from the shear stress or frictional forces between alveoli that have different time constants and may also result in surfactant being milked from the alveoli. During the early phase of ARDS, it is important to keep extrinsic PEEP high enough to at least to exceed the inflection point on a slow or static pressure volume curve. It is generally accepted by clinicians that the deflation limit of a slow pressure volume loop best approximates the end expiratory pressure range required to prevent alveolar collapse. Maintaining extrinsic PEEP above this pressure range helps to prevent opening and closing of small airways in alveoli. Even if a ventilator does not have a graphics package, this curve can be graphed by hand. Extrinsic PEEP may also be beneficial in later stages of ARDS to maintain oxygenation and reduce the FiO2 levels of less than 50%. Clinicians generally use the first 30 to 60 minutes following initiation of mechanical ventilation to gather information that can be used to evaluate the effectiveness of ventilatory support. These data includes vital signs, breath sounds, and assessment of respiratory mechanics. Ventilator graphics can also be a valuable resource when evaluating the patient-ventilator interaction. Once an initial physical assessment is performed, an arterial blood gas sample should be obtained to evaluate the patient's respiratory and acid-base status. Evaluation of ABG results can be divided into three parts: acid-base status, ventilation, and oxygenation status. pH, alkalinity, acidity, and bicarbonate, PaCO2, or partial pressure of carbon dioxide, and oxygenation status, SeO2, CaO2, and oxygen delivery. The following discussion focuses on those factors that can alter PaCO2 during mechanical ventilation, including minute ventilation, physiological dead space, and CO2 production. A change in minute ventilation is often required after a patient is placed on mechanical ventilation. It is not uncommon to use full ventilatory support initially and then make adjustments after an initial assessment is performed. During mechanical ventilation, adjusting the set tidal volume or rate or frequency can be used to adjust respiratory alkalosis or acidosis. The equations is the known PaCO2 times the known minute ventilation equals the desired PaCO2 times your desired minute ventilation. When PaCO2 is elevated, greater than 45 millimeters of mercury, and pH is decreased of less than 7.35, respiratory acidosis is present and alveolar minute ventilation or alveolar ventilation is inadequate. Acute respiratory acidosis is associated with either parenchymal lung problems, airway disease, pleural abnormalities, chest wall abnormalities, neuromuscular disorders, or central nervous system problems. In patients requiring mechanical ventilation, respiratory acidosis generally can be corrected by adjusting the set tidal volume or frequency to achieve the desired minute ventilation, regardless of whether the patient is receiving volume-controlled or pressure-controlled ventilation. Increasing minute ventilation will decrease the PaCO2. Recommended guidelines are to target a tidal volume of 6 to 8 mLs per kilo by ideal body weight, while assuring that the plateau pressure is maintained less than 30 degrees centimeters of water pressure. Tidal volume and breathing frequency adjustments should be based on patient's pulmonary pathology. It is important to understand that the 6 to 8 mLs per kilo range is an average. If the tidal volume is at the upper limit of this range and plateau pressure is greater than 30 centimeters of water pressure, then tidal volume may be decreased to achieve a lower plateau. With pressure control CMV, the set pressure is generally adjusted to obtain the targeted tidal volume. PCCMV is time cycled. If the inspiratory time is short, increasing it may also increase volume delivery without requiring an increase in pressure. When PaCO2 is decreased, less than 35 millimeters of mercury and pH increases greater than 7.45, then respiratory alkalosis is present, indicating that the alveolar ventilation is excessive. Common causes of respiratory alkalosis include hypoxia with compensatory hyperventilation, parenchymal lung disease, medications, mechanical ventilation, central nervous system disorders, anxiety, and metabolic problems. In mechanically ventilated patients, hyperventilation is often the cause of respiratory alkalosis. To correct respiratory alkalosis in this situation, the clinician should decrease ventilation during volume-controlled ventilation by decreasing frequency and, if necessary, by decreasing tidal volume. If pressure-controlled ventilation is used, the clinician should decrease frequency first and then decrease set pressure if necessary. Patients in apparent respiratory distress may present with metabolic acidosis. These patients often are struggling to lower the PaCO2 to achieve some degree of hyperventilation to compensate for the metabolic acidosis. As a consequence, these patients are at risk for developing respiratory muscle fatigue. In this situation, mechanical ventilation is indicated to meet the minimum goal of compensated hypocapnia. Treatment for metabolic acidosis includes initiating effective therapy to address the cause of the acidosis and assessing the need to reverse the acidemia with the administration of an alkalizing agent. Treating the underlying cause of acidemia and making sure vascular volume and cardiac output are normal, in addition to ensuring adequate oxygenation, are essential. These actions allow time for the normal metabolism of organic acids, such as lactic acid and keto acids, and allow time for the kidneys to generate bicarbonate to replace losses. Controversy also is happening regarding the benefit of using alkalinizing agents, such as bicarbonate administration in the treatment of metabolic acidosis. Lowering arterial CO2 is also controversial, but if the patient is losing the struggle to maintain high ventilation with spontaneous breathing, assisted ventilation may be necessary to avoid respiratory failure. As with metabolic acidosis, metabolic alkalosis treatment involves identifying the underlying cause and reversing those factors leading to the alkalosis. In severe cases, carbonic anhydrase inhibitors, acid infusions, and low bicarbonate dialysis may be required. Uncomplicated metabolic acidosis or alkalosis is not usually associated with alveolar hypoventilation as a compensatory mechanism because of the resulting hypoxemia that occurs with severe hypoventilation. Remember that the PaO2 will fall as the CO2 rises. Thus, hypoventilation is accompanied by hypoxemia in a patient who's breathing room air. The hypoxemia will cause stimulation of the peripheral chemoreceptors, resulting in increased ventilation. Only in rare circumstances does full compensation of metabolic alkalosis occur. Improving the ventilatory status of a patient with hypercapnic respiratory failure can be accomplished by improving alveolar ventilation, reducing physiological dead space, and reducing carbon dioxide production. Improving oxygenation, on the other hand, involves using various patient management strategies, such as administering supplemental oxygen, applying PEEP or CPAP, and patient positioning. Although the terms hypoxia and hypoxemia are used often interchangeably, it is important to recognize that hypoxia is defined as a reduction of oxygen in the tissues, whereas hypoxemia refers to a reduction in the partial pressures of oxygen in the blood. hypoxemia is relieved. Methods used to set optimum PEEP are provided along with a review of the pressure volume loops. Additional uses of PEEP are also discussed along with the description of the effects, complications, and consequences associated with the discontinuation of PEEP. Listed below are also other factors assessing oxygenation, such as the FiO2, your SpO2, ABGs, hemoglobin, abnormal hemoglobin, your partial pressure of oxygen in the arterial blood, your AA ratio, the PF ratio, shunt, cardiac output, SvO2, and CvO2. So the most common parameters used to assess oxygenation status of patients are the FiO2, SpO2, ABG, hemoglobin, the presence of abnormal hemoglobin species, PaO2, your AA ratio, PF ratio, shunt, cardiac output, SvO2, and CvO2. Measuring oxygenation delivery to the tissues provides valuable information about oxygen availability to the tissues. Oxygen utilization by the tissues can be determined by measuring arterial to mixed venous oxygen content difference, oxygen consumption, and cardiac output, and mixed venous oxygen saturation. The FiO2 should be measured at regular intervals or continuously if possible to ensure that the patient is receiving the appropriate concentration of inspired oxygen. When changes in the FiO2 are initially made for adults or children, ABG should be measured within 15 minutes, although some clinicians choose to obtain a sample after 30 minutes. Every attempt should be made to prevent complications associated with oxygen toxicity by administering an FiO2 below 0.6 while maintaining the PaO2 between 100 and 90 millimeters of mercury and the CaO2 near normal. This goal is not always possible, and sometimes a higher FiO2 is required. The SpO2 can be used to titrate FiO2 once the relationship between the PaO2 and SpO2 has been established. A goal for maintaining SpO2 at greater than 90% is appropriate. It is important to understand, however, that the SpO2 will not always correlate perfectly with PaO2. Some patients will have a large discrepancy between SpO2 and PaO2 and need to be monitored more carefully. Although the inspired oxygen percentage can be determined using multi-use oxygen analyzers, more ICU ventilators have built-in oxygen analyzers that can provide continuous measurement of FiO2. The ABGs obtained after mechanical ventilation is initiated are compared with FiO2 being delivered. A linear relationship exists between PaO2 and FiO2 for any patient as long as the patient's cardiopulmonary status remains fairly stable. In other words, the minute ventilation, cardiac output, shunt, the VD-VT ratio must not change significantly between the time the ABG comparison is made and the FiO2 is changed. Most of the time, this is the case because ventilator changes are made quickly after blood gas results are obtained. This equation provides a reliable method for making appropriate changes in the FiO2 to achieve the desired PaO2. So the desired FiO2 is equals the PaO2 desired times your known FiO2 divided by your known PaO2. Making adjustments in FiO2 has a greater effect on patients with hypoventilation and reduced VQ, in which higher alveolar oxygen has better access to pulmonary blood flow than situations of pulmonary shunt. Although the exact safe level of FiO2 in mechanically ventilated patients is not known at this time, it is generally agreed that maintaining a high FiO2 or greater than 60% can result in oxygen toxicity. Besides the tissue damage associated with the long-term use of oxygen at 100%, it is also has an additional complication. Breathing 100% oxygen can lead to absorption atelectasis and increased intrapulmonary shunting, which further contributes to the hypoxemia. FiO2 should be kept as low as possible. Although the lower limits of permissive hypoxemia remains controversial, most practitioners agree that a target PaO2 of 60 and SpO2 of 90% are acceptable lower limits for most adult patients. If the PaO2 remains very low while the patient is breathing an enriched oxygen mixture, significant shunting, ventilation perfusion abnormalities, and/or diffusion defects are present. In these cases, other methods to improve oxygenation besides increasing FiO2 must be considered. Because PEEP is so frequently used to increase mean airway pressure and improve and maintain oxygenation, it occupies a key role as a technique for treating acute parenchymal lung injury, such as severe atelectasis associated with various pulmonary pathologic processes. The goal of using PEEP is to recruit collapsed alveoli while avoiding overdistension of already open alveoli. It is important to set an appropriate level of PEEP that avoids overdistension while maintaining alveolar patency and preventing alveoli from collapsing during exhalation of a tidal volume. Both overdistension and repeated collapse and re-expansion of alveoli are associated with ventilator-induced lung injury. Generally, PEEP is used when a problem in the lungs results in collapse of alveoli and small airways. If a significant number of alveoli collapse, more areas of the lungs are perfused but not ventilated, resulting in a shunt-like situation. When PEEP is set on a ventilator, the expiratory valve of the ventilator closes when the expiratory pressure drops to the set PEEP level. This traps a certain amount of pressure and volume in the lungs that can prevent or reverse alveolar collapse and reduce the amount of pulmonary shunting. Although CPAP can also be used to reduce shunting, its application is for patients who are spontaneously breathing. CPAP can be achieved with a mechanical ventilator by setting the mode selection switch to the spontaneous or CPAP mode, and then setting the desired level of CPAP in the PEEP control. CPAP can also be delivered to spontaneously breathing patients using a freestanding setup, such as the one without a mechanical ventilator. It is important to recognize that using freestanding CPAP devices carries a potential liability because these devices are usually homemade and have not undergone a formal evaluation for approval by an authorized independent agency. Two levels or ranges of PEEP can be employed: minimum or low PEEP, also called physiologic PEEP, and therapeutic PEEP. In most situations, it is appropriate to use a minimum level of PEEP, 3 to 5 centimeters of water pressure, to help preserve a patient's normal FRC. FRC usually decreases when a patient is intubated or placed in a supine position. The reduction in FRC is due primarily to the abdominal contents moving upward and exerting pressure on the diaphragm. Because only 3 to 5 centimeters of water pressure is applied with minimum PEEP, it is usually not considered a problem in terms of causing complications. Therapeutic PEEP is PEEP that is greater than or equal to or greater than 5 centimeters of water pressure. It is used in the treatment of refractory hypoxemia caused by increased intrapulmonary shunting and ventilation perfusion mismatching, accompanied by a decreased FRC and pulmonary compliance. High levels of therapeutic PEEP, like equal to or greater than 15 centimeters of water pressure, are beneficial for a small percentage of patients with ARDS. Because high levels of PEEP are often associated with cardiopulmonary complications, physiological response to therapy must be monitored carefully. ARDS remains a prime example of a pathophysiological state in which PEEP is used as an effective means of improving oxygenation. Patients with ARDS do not benefit from mechanical ventilatory support without PEEP. Although collapsed alveoli may open during a positive pressure inspiration, patients with ARDS do not benefit from mechanical ventilatory support without PEEP. Although collapsed alveoli may open during a positive pressure inspiration, unstable alveoli and airways tend to collapse if the airway pressure returns to ambient pressure during expiration. Because approximately 2/3 of the respiratory cycle is spent in expiration, blood passing through these areas of collapsed alveoli during expiration creates a shunt-like state which perpetuates hypoxemia. Patients with ARDS benefit from PEEP because it helps to prevent collapse of the small airways and alveoli, and thus it aids in recruiting closed lung units. The edema-filled alveoli may also have their volumes partially air-filled with this technique as well, leading to the restoration of FRC. Lung compliance and gas distribution are enhanced, thereby reducing the shunt effect of venous admixture and improving oxygenation. The indications for initiating CPAP are similar to the criteria used for initiating PEEP. The primary difference between using CPAP versus PEEP is that the patient provides the work of breathing at all times during CPAP. If a patient is capable of breathing spontaneously without much difficulty and is able to maintain an acceptable PaCO2, then CPAP is appropriate. Ultimately, PEEP allows for the reduction of FiO2 because it improves oxygenation and helps avoid the complications associated with high FiO2 in certain disorders. Examples of disorders that may benefit from the use of PEEP includes ARDS, cardiogenic pulmonary edema in adults and children, and bilateral diffuse pneumonia. Once a patient's clinical condition indicates that PEEP or CPAP therapy is warranted, it is prudent to initiate this form of therapy as soon as possible. High peak pressures, which is greater than 35 centimeters of water pressure, along with FiO2 values of 0.5 or greater, may damage alveolar cells type 1 and 2 in less than 24 hours. Therefore, CPAP or PEEP should be initiated early in the course of therapy to avoid lung damage from high pressures, volumes, and FiO2. As always, if you have any questions or concerns, please refer to your course instructor and/or your textbook.